This program is brought to you by Stanford University. Please visit us at stanford.edu.
It is my distinct pleasure to introduce our first speaker, Dr. Dianna Milewicz, who comes to us from the University of Texas at Houston, where she is not only professor and director of the Division of Medical Genetics, but is also the holds the George H.W. Bush Chair in Cardiovascular Medicine. We've heard a lot about pathophysiology of aneurysms, as well as the epidemiology of aneurysms, and a number of the speakers have touched on the whole topic of genetics in the family history of this disease. And now we're going to hear the real deal from Dr. Milewicz. Dr. Milewicz has had a storied career. She's earned a number of honorary distinctions, including awards from the Doris Duke Foundation, the Marfan Foundation, as well as her home institution. So I'd like to take the time to introduce Dr. Milewicz and look forward to her discussion today. And her title of her talk is?
Genetic Determinants in AAA.
How about that? There you go.
Thank you. I'd like to point out that the George Bush Chair is George Bush Sr., just in case. There's only one place that I've been where they actually cheered after it was announced I was the George Bush Chair. And can anybody guess where that was? Well, no, not even in Texas. We're not laying claim to him. No, Yale, where they both graduated from. When I was giving grand rounds there, I wouldn't say they cheered, there was polite applause. Okay, so I have a real tough talk to give this morning. Ron was quite insistent that I talk about genetic determinants of abdominal aortic aneurysms. And the bottom line is there's really not been any genes that have been identified that lead to this disease that have been comprehensively studied and definitely identified as genetic predispositions for these diseases. So what I'm going to do is talk about what we know currently about the state and what I sort of recommend that the direction we need to go to start identifying these genes. And I'm going to start out with this case report that was actually published back in 1972. This is it was a 48-year-old woman who presented with a pulsatile abdominal mass. She was a non-smoker, non-hypertensive. Cholesterol levels weren't even checked back in those days. She had had an enlarged aorta noted 10 years earlier when she underwent a C-section. And she, on imaging, had a fusiform abdominal aneurysm and an aneurysm of her hepatic artery, shown here, and then she had this extensive fusiform aneurysm extending up to above the renal arteries. She underwent surgical repair with no complications, but she died at the age of 58 of an acute aortic dissection. So I started with this case report because this woman here just really tells us that she has an underlying gene mutation as the cause of her abdominal aortic aneurysm. Somebody shouldn't have an abdominal aneurysm. A woman in particular shouldn't have an abdominal aneurysm at this age, and certainly not during their childbearing years. And I'll talk about her again in a few minutes because we actually have found the underlying genetic mutation that caused her abdominal aneurysm. So I'm just going to start from the very beginning and say, okay, we've got our genes and our DNA is packaged into our chromosomes. We have 22 pairs of autosomes in our sex chromosome. And we get each pair of an autosome, we get one pair from mom, one pair from dad. And so this is basically, first of all, genetically, we're made up of our parents completely. If you thought about that previously, it may have saved you years of psychotherapy. But this slide really illustrates why it's been so hard to identify those genetic variants. In our human DNA, the code is the base pairs, the nucleotides. And we have 3 billion base pairs in our genome. So despite the completion of the Human Genome Project and the sequencing of the entire genome, we still are looking in the vast vast majority of cases, just for one base pair out of 3 billion base pairs in the human genome. So that's part of the reason why it's been so hard to identify genes for common diseases like abdominal aortic aneurysms. But I can give you a whole list of other human common diseases where it's been very difficult to find the genes that predispose, the genetic variants that predispose individuals to disease. And just to remind you, I sort of think of genetic disease as a continuum from purely genetic diseases. These are those genetic disorders that are due to mutations of just a single gene. So we've got about 30,000 genes in our human genome. And so these are syndromes like cystic fibrosis, sickle cell anemia, that when you mutate that one gene, no matter what environment you put yourself in, more than likely, sooner or later, you're going to have the disease. And then at the other end is purely environmental diseases like trauma. You're driving down the road, an 18-wheeler sideswipes your car, you're going to have a traumatic injury no matter what genes mom and dad gave you. And so most common diseases fall in between environmental and genetic. So we get a set of genetic variants from our parents that predispose us to the disease, and then what environment we put ourselves in predicts whether or not we're going to get that disease. Now, even then, when you take these common diseases, for all of them, there appears to be a subset that is anywhere from 6 to 20% of the disease that's due to single gene mutations. And so for breast cancer, we know that's BRCA1 and 2. For coronary artery disease, that's genes like for LDL receptor mutations that lead to familial hypercholesterolemia. So I can give you a list of all sorts of diseases where we can find single gene mutations. And identification of those single gene mutations has really helped us understand the underlying molecular defects leading to that disease. And I think that with abdominal aneurysms, there's clearly common genetic variants that get inherited that predispose you, plus obviously the environment and the known risk factors are part of the disease progression. But I still think, based on the patients that I've seen, there's still a subcomponent that's due to single gene mutations that can be inherited in a family. In some cases, that's associated with the syndrome, and I'll talk about some of those. But also, I think there's families out there that can be used to map these genes. And then, obviously, these genes, the common variants, those are going to be identified through genome-wide association studies. And we're just beginning to gear up on genome-wide association studies, and I believe that there's already some GWAS studies going on for abdominal aneurysms using cohorts in Europe and possibly in Australia and New Zealand. So here we're talking about two different types of genetic variation. One's a mutation leading to a Mendelian inherited disease, and these are very rare changes in the DNA sequence, and they're almost predictive that it greatly increases the likelihood that somebody's going to have the disease. For cystic fibrosis, that's 100%. For some other diseases, the penetrance can vary anywhere from 60 to 100%, but most diseases, it increases your risk significantly. But polymorphisms are variants that we all have in the in the population, and they can either be benign or they can predispose to disease. So we have 3 billion base pairs. In those base pairs, there's variations in 3 million sites, and it's estimated that about 300,000 of those variants will predispose to different diseases in humans or predict things like your skin color, your hair color, and so on. So we're just and height, weight, and also whether you have schizophrenia or not, and whether you like mom or dad, and so on. And this is just to remind you that those Mendelian diseases can be inherited in a dominant manner or an autosomal dominant or X-linked. And I just want to remind you about dominant inheritance, because most cardiovascular diseases are dominant genes. You have one normal gene and one mutant gene. So when you have the disease, you have a 50-50 chance of passing it on to your children. Okay? Unlike cystic fibrosis, where you need 2 copies of the mutant gene. So, and what I see in the abdominal aneurysm families that we've identified, that in most cases it is an autosomal dominant inheritance. So here's a list of the genetic syndromes where we know that the patients primarily have other vascular diseases, but they can present with abdominal aortic aneurysms. Probably the most common cause of abdominal aortic aneurysms is vascular Ehlers-Danlos syndrome. In patients with Marfan syndrome and patients with TGFBR1 and 2 mutations, it's actually very rare to see abdominal aneurysms in those. I think tuberous sclerosis, I won't mention that syndrome further, but tuberous sclerosis is very interesting because this is a gene that it's due to mutations in 2 different genes. You have patients with TS1 mutations and other patients with TS2 gene mutations. But both of these genes upregulate mTOR signaling in the smooth muscle cells and other cells. And it's primarily a neurologic problems with a predisposition to cancer, but a rare patient will get an abdominal aneurysm at a very young age. And I wonder if this disease isn't telling us something about the formation of abdominal aneurysms. And in Houston about 2 years ago, there was a 3-year-old child who presented with a 13-centimeter abdominal aneurysm that Dr. Azizadeh, where's Ali? Are you here? He was involved in the care of that patient. So they can present with dramatic, very early onset abdominal aneurysms. We recently had the opportunity to look at the TS mouse, the TS2 mouse, and the heterozygous mouse in the abdominal aorta clearly has an abnormal aorta compared to the wild type. So this might open the door to be able to begin to understand why there's a rare patient with TS that presents with such an unusual vascular disease, an abdominal aneurysm. So these syndromes are due to a single gene that's mutated. I just want to go through these quickly. Vascular EDS has a number of clinical features. The primary vascular disease is aneurysm and rupture of medium-sized arteries. And then but what is almost diagnostic of picking up these patients is that when the surgeons go to repair the vascular disease, the tissue is very friable and doesn't hold sutures well. They're also prone to rupture of the colon and rupture of the gravid uterus. And they also have hernias, and women, when they carry children, will often have premature births. This is due to mutations in type 3 collagen. And I've got a couple pictures of a patient that is actually Dr. Azizadeh's patient that had an abdominal aneurysm at the age of 40. He was back in the hospital at Herman Hospital yesterday morning when I saw him. And he more than likely has a type 3 collagen mutation. He now has bilateral iliac artery aneurysms, and he has many of the clinical features we see in EDS patients. Here's his previous abdominal aneurysm scar that he had repaired at the age of 40, and you can see that this scar is atrophic, it's poorly healed. He actually has an incisional hernia, and at that time they had trouble getting the sutures to hold. And even with the more recent repair, they had trouble with the sutures. And then it may be difficult to see this, if not impossible, but you can see his veins through his skin on his chest. And I can see him on the computer, but I don't know if you can see him here. And that's also very diagnostic of vascular EDS, is this very thin tissue. Now, TGFBR1 and 2 mutation patients have many of those similar features of the thin skin, atrophic scars, and unlike the vascular EDS patients, they present primarily with ascending aneurysms and dissections, but there are patients that will present with abdominal aneurysms. And in fact, the case report that I presented at the beginning of the talk, actually that woman has a TGFBR1 mutation as the cause of her abdominal aneurysm. Now, there's a full spectrum of aortic disease in these patients. They can present as children with Loeys-Dietz syndrome, and then they can present all the way up to presenting at the age of 80 with an acute dissection in families that have dominant inheritance of aortic aneurysms and dissections without any of the phenotypic features that we see in in patients with Loeys-Dietz syndrome. This woman's a 55-year-old woman that had an acute aortic dissection who has a TGFBR2 mutation. Now, what's interesting is that in the families with TGFBR1 mutations, we're seeing a difference in presentation of the vascular disease between men and women. And this family actually illustrates this. This is a family that was actually described, that this individual is that first case report that I'm sorry, it's this individual. This woman is the woman that presented with the abdominal aneurysm, went on to die of a thoracic aneurysm. Her sister had presented with a carotid artery dissection, and now she's sitting with an ascending aortic aneurysm that she refuses to have repaired. She watched 3 of her sons die of acute aortic dissections at the age of 22 or younger, at very young ages. And this individual fortunately had prophylactic repair before of his ascending aneurysm, thoracic aneurysm. Then the girls, the other women in the family, all presented with dissections or aneurysms outside the ascending aorta. And I think these all presented with carotid artery dissection. So this is an interesting scenario, because here you have one gene, the TGFBR1 gene, that is presenting with different vascular disease in the family. And I just want this group in particular to be aware of this, because it won't be unusual that you may see a patient with an abdominal aneurysm, carotid artery dissection in a woman, and then get a family history of thoracic aortic disease. And if that's the case, you should think mutations in TGFBR1 and possibly TGFBR2. And another feature that's really diagnostic of TGFBR1 and 2 is tortuous arteries. And even this woman in that original case report, it was noted that her mesenteric artery at the time of surgery they noted it was very tortuous. And then finally, a rare patient with Marfan syndrome will present with an abdominal aneurysm. And as Dr. Toulaney talked about last night, this is due to mutations in fibrillin, which makes up a component of the elastic fiber. And that with mutations, it's felt that there's excessive active TGF-beta that gets released into the tissue, and that's what drives the aneurysm formation. So those are the syndromes that can predispose to abdominal aortic aneurysms, and these are some of the red flags that I've already gone over that should make you think that maybe this patient has an underlying genetic mutation. But these genes really haven't provided us insight into the pathogenesis of abdominal aortic aneurysms. And so we need to go a little bit further than that. Now, it's clear from multiple clinical studies that abdominal aortic aneurysms aggregate in families, and that there's a very high risk to brothers of patients with abdominal aortic aneurysms, and I think all of you are aware of that. And right now there's attempts made to revise the recommended screening to include screening family members when there's a positive family history. And the overall risk to siblings of a patient with an abdominal aneurysm, lifetime risk is almost 20%. So there appears to be, based on these clinical studies, a very strong genetic component. Now the question is, how much of that is due to inheritance of a single gene mutation in somebody that doesn't have a known syndrome? And does that occur? And how much is it these common variants in the population that just predispose people to the disease? Well, here's a family we were referred that actually approached us about participating in our thoracic aortic study because they had multiple members with abdominal aneurysms. These individuals have fairly young ages of onset of their abdominal aneurysms. In addition, it's being inherited in what appears to be an autosomal dominant manner. So after seeing families, numerous families like this, I wonder if there isn't a non-syndromic single gene disorder that's responsible for a small subset of the disease. In thoracic aortic disease, it's estimated that 20% of the disease is due to a single gene. And I wonder if we looked a little deeper for these families and did more imaging of people that are felt not to be affected in particular the males in the family, if we might be able to find families large enough to be able to map these genes. Here's another interesting family in our study where these women died in their 60s of abdominal aortic aneurysm rupture. That this individual had an aortic dissection at the age of 66, and this woman and the grandmother up here had intracranial aneurysm ruptures. And so we see, once again, some variability in the vascular disease. And the story with the TGFBR1 mutations is telling us that possibly that these types of families with vascular disease and different vascular beds can all be due to one single gene mutation. And then, so why map these genes and find them? Well, I think that our work in ascending aneurysms and dissections has really helped us understand, come up with a proposal or a hypothesis as to what might be the underlying defect. And what we've done is taken large families like this, where everybody who's shaded in black has presented with an acute aortic dissection. And if we get families that are large like this, we can actually map the gene in that single family. And the reason we want to use single families is because there's more than likely going to be multiple genes that lead to abdominal aortic aneurysms, just like we already know that there's multiple genes that lead to aortic ascending aneurysms and dissections. And so you need to use one large family to be able to map and identify these genes. In this family, we were able to go through and map the gene to chromosome 10, and then once you've got it in an interval on the chromosome, you can go through and start sequencing genes in that interval. We found our single base pair change. It was a C to a T change in this family, and it turns out that this family has ascending disease due to mutations in a contractile protein in smooth muscle cells. They have mutations in smooth muscle cell alpha-actin. And then we go back through the rest of our families, and 15% of our families will have mutations in this gene. So this appears to be a pretty major gene for aortic aneurysms and dissections. So, and we've also done some cell biology to show that patients, here's an immunofluorescence of a control smooth muscle cell that shows the alpha-actin contractile fibers known as the thin filaments in the muscle cell in a control. And then here's two patients with alpha-actin mutations, and as you can see, they're just not making these filaments due to the missense or single base pair change that alters the protein and disrupts basically all the filaments in the smooth muscle cell. So we predict that these mutations cause problems with smooth muscle cell contractility. Now, we've gone through using different families. We and other investigators have mapped a series of genes, and you can see that both the smooth muscle cell alpha-actin and the smooth muscle cell beta-myosin, two components that are important for contraction, are mutated in aortic aneurysms and dissections. And then this has led us to propose that this may be muscular dystrophy of the smooth muscle cells, that when you mutate alpha-actin and beta-myosin in the skeletal muscle, you get muscular dystrophy. And in the smooth muscle cell, as I said, is predicted to disrupt contraction, and that this disrupt these contractile filaments that are so important inside the smooth muscle cells, because beta-myosin makes up the thick filaments in the contractile unit, and alpha-actin makes up the thin filaments. And this is just, I'll skip that. So I do think it's worthwhile trying to identify large families with multiple members, and I certainly would be happy to collaborate with anybody that had a family that was large enough to map a gene for abdominal aortic aneurysms. Now, what about to hopefully move forward in abdominal disease to try to identifying what the genes are in that particular disease, in abdominal aneurysms. So what about the status of identifying those polymorphic common variants that predispose to disease? And the only variant that's been conclusively identified to be associated with abdominal aneurysms was a variant on chromosome 9p. There's 2 SNPs on 9p. It turns out that these variants are associated with multiple vascular diseases: abdominal aortic aneurysms, intracranial aneurysms, and coronary artery disease. So initially there was a genome-wide study to try to find variants associated with coronary artery disease. Multiple groups identified the SNP on polymorphism, single nucleotide change, that probably 50% of the people in this room have that variant. But this variant is enriched in people with coronary artery disease, and is also more common in people with abdominal aneurysms and intracranial aneurysms. So that's, by definition, this is associated with the disease. And so there's been no genome-wide scans for abdominal aneurysms, but like I said, those are beginning. And they just took the SNP identified in coronary artery disease and looked at its role in other vascular disease. So here's a summary of the data. And you can see here that they had a large number of cohorts with abdominal aneurysms. This number is the number of controls, people without the disease, and this is the number of cases that they looked at. And you can see most of their cohorts came from outside of the US. And some of them, like the New Zealand cohort, is actually quite large. And in the most cases, the controls were not image-negative controls. But you can see across the board that this variant gave significant association with the disease, but only confers a risk of approximately 1.3-fold. So the risk to have this variant isn't as great as the risk of smoking cigarettes through your life for abdominal aortic aneurysms. So this SNP was associated with abdominal aneurysm, intracranial aneurysms. Peripheral arterial disease showed some slight associations, but only conferred on average a 1.1-fold risk. So they weren't willing to claim that it predisposed to peripheral arterial disease. Interestingly enough, it didn't appear to be associated with strokes, but other groups are looking at that. So to sort of summarize, we have a SNP on chromosome 9 that increases your risk of getting abdominal aneurysm 1.3-fold. So it's not particularly useful in predicting who in the population will get an abdominal aneurysm and who won't. Family history or a history of cigarette smoking is a better predictor of and being male is a much better predictor of who's going to get the disease. In addition, this 9p SNP falls in the middle of what we used to call junk DNA. It doesn't hit a gene, it doesn't lie anywhere near one of the genes on chromosome 9, so we have no idea what it does at the molecular level. And it's sort of difficult to figure it out if it's sitting in the middle of DNA that you don't know the function. And so although it was very exciting to have the first genetic variant associated with abdominal aneurysm, it's not in a gene, so we have no idea what it tells us about the molecular basis of this disease. So I think as I said, genome-wide associations are in progress, and I think that they have a great potential to identify other genetic variants that lead to the disease and maybe tell us something about the molecular pathways and possible pharmacologic targets in the future. And to do these studies, and one of the reasons I put this slide up is you just need a large number of patients, DNA from patients banked to be able to do these association studies. So I would urge people that have busy practices to consider banking DNA from their patients. And I know Dr. Baxter is interested in trying to get more of a national-wide initiative to get these samples banked. So in summary, identifying rare genetic mutations in abdominal aneurysms has the potential of helping us understand the underlying molecular mechanism, but we need to bank DNA for patients for future genome-wide association studies, but also for single gene mutation studies. And then once again, I think the approach to finding those single genes is to use large families with multiple members. So thank you, and I'm happy to answer any questions.
cogent and comprehensive review. Any questions for Dr. Milewicz? Dr. Baxter?
That was a great talk.
Thank you.
I have two question and a comment. You didn't mention the type 3 mutation that Helena Kavimi and Gerard Trump have found in association with aortic aneurysms. That was published many years ago.
Which mutation?
It's a type 3 collagen mutation.
So I mentioned that type 3 collagen mutations can predispose to abdominal aneurysms, so it falls in that. I actually, in looking at that data, they didn't confirm those were mutations causing the disease in that paper.
Okay.
And so I didn't mention that paper. And the same thing, they've mapped a gene on chromosome 19, but once again, that hasn't been validated by other people's mapping studies, and they haven't found the gene at that site. And actually, statistically, they haven't reached statistical significance, high enough significance to confirm there's a gene there. I think they're right that there is a gene there, but they just haven't reached the standard level that we expect.
Okay.
For genetic studies.
And then I guess the other thing is that when you talked about the contractile protein abnormalities in the smooth muscle cell, we sort of think of the aorta as a conductive vessel less than a contractile vessel. And I wondered if you had any histology from those patients from the normal segments of the aorta, just to see if those abnormalities in the contractile proteins led to abnormalities in the structure of the aorta.
Well, most patients won't give us their normal aorta, unfortunately. And anybody that's willing to give us their normal aorta will take it. No, so we haven't had the opportunity to look at that. By imaging, the structure of the aorta is just fine. And the reason why I think contractile function is so important in the ascending aorta is because that takes the major forces from the contractile blood throughout our lifetime. So I think it tells us that it's not only the elastic fibers that provide that elasticity and structural support to the aorta, but it's also the smooth muscle cells, and that they do play a role of contracting. And their function is to contract with every pulse pressure to regulate pulse flow and to regulate flow and pulse pressure. So in the ascending aorta, I think that's particularly important because we find these mutations in the contractile proteins. And just physiologically, that makes sense that that would be the vascular bed affected.
And like for the most of the aneurysm studies, like some of the things we saw yesterday, the normal samples are the adjacent tissue that sometimes is collected at surgery. So that helps to look at the non-affected segment to see if it's a epiphenomenon or if it's a real problem.
So if we look at the adjacent sections, and molecularly they have abnormalities, but the structure is intact, that the layers of elastin fibers, but they'll have increased proteoglycans and some degradation of those elastic fibers.
Dr. Norman? Nope. It's okay.
Hi, very nice talk. Just as a comment, there is some data now coming out about the Chrome 9 SNP that was discovered, and actually it turns out it does actually have an RNA non-coding relationship, and there is some functional stuff that's coming out.
Is it a microRNA?
It's non-coding RNA, but its exact function isn't clear, but there are some functional studies coming out relating to that SNP that shows that it does alter vascular compliance. So we are getting some mechanistic links to that as a follow-up to that observation. So it's not just junk DNA.
It does affect compliance of the vessels? Make them stiffer? Or? Okay.
Very good.
Okay. Thank you.
Paul? Sorry, Dianna, one more question?
Oh, okay.
One of the problems with familial studies is you've got a phenotype that's not really detectable until 50 or 60 or even 70, and so clinicians will see a family where there may be a sibling or something like that, but the motivation to really look further is not there because the next generation are too young to detect the phenotype. This might be a question for the people doing some of the imaging talks, but should we be imaging the younger generation even in their 20s or whatever and looking more carefully for subtle early phenotypic manifestations.
I think that's a great suggestion. With a large French family that has a beta-myosin mutation, they were able to show that there was decreased compliance of the ascending aorta in individuals that carried the mutation, and that was there before they had anatomic evidence of enlargement of the aorta. And so it virtually marked who had inherited the genetic defect and who had not. In some of our families, we find other phenotypic features. In the alpha-actin families, they have levato reticularis, which is a vascular occlusive rash. But that's almost, it's predictive of who carries the mutation down to the age of 3 years of age in these families. So I think that if careful phenotyping and then better imaging of unaffected family members has the potential. But at the same time, if there's a single gene mutation, you would expect this earlier age of onset. So you'd expect to see disease in the 50s, 60s. And then what we've done with aortic dissections, because they do cause death, is that you can go out and get first, second degree relatives, and that increases your power to map these genes. And oftentimes, I didn't have time to show it, but we can often find a large number of patients in these families with asymptomatic aneurysms.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.